Hi, my name is Danae Barkey, and I am the Executive Director of HCU Network America, as well as an adult homocystinuria patient. I'd like to welcome you tonight to our webinar, The Homocystinuria is a Big Complicated Family, with our guest presenter, Dr. Kimberly Chapman. Dr. Kimberly Chapman is a geneticist and metabolist at Children's National DC and is the senior author on the guidelines for diagnosis and management of cystine beta-synthase. In addition to being author on this, Dr. Chapman is also a medical advisor for HCU Network America as well as a board member. Dr. Chapman, I'm turning it over to you.
I'm going to minimize the poll a little bit. So I want everybody to ask questions as we go along. And so I think there's a chat button, and you can certainly ask questions as we go along. Please stop me. And Danae, if you'll just let me know if something comes up on the chat. As I go along, if I say something that doesn't make sense, something that is unclear, something you never heard before, because I think homocystinuria is really complicated. You know, what really binds folks with homocystinuria together? It's homocysteine, right? And so what are we going to cover today? And as I said, stop me if I say something that doesn't make sense, but we're going to talk a little bit about the inherited homocysteinurias, how they're similar, right? Because that's what binds us together. That's what makes us a family. And then we're going to talk about how the inherited homocysteinurias are different and why. And because the parts that make them different is what gives you differences between the diseases and among the diseases. And then I'm going to have a pretty broad-reaching conversation about therapies. I'm not going to do a lot of very specific things about therapies because the family of homocystinuриas are taken care of in slightly different ways, which is why some of you who have a family member or have cobalamin C yourself is taken care of different than classical homocystinuria. And, you know, we talk about diet for classical homocystinuria, and we talk about no diet for cobalamin C. And so I think it's kind of important to talk about that. So what's the binding? What's the thing that binds us together? And let's start with a few definitions, because I think these are terribly confusing because you hear them all the time. What is homocystinuria and what's hyperhomocysteinemia, right? So homocystinuria just says you have homocysteine detectable in your urine. And usually when it's used, it denotes an inherited metabolic disorder. Now, hyperhomocysteinemia is anytime there is more than the normal amount of homocysteine in the blood. This does not denote an inherited metabolic disorder. And you'd say, well, why would there ever be elevations in homocysteine? So total homocysteine normal levels are usually a little less than 12 micromoles per liter. In individuals who have B12 deficiency or folate deficiency, those individuals can have elevated total homocysteines. In fact, one of the measures for B12 that is recommended by the American Board of Internal Medicine is to check total homocysteine to determine if somebody is B12 deficient. And individuals who have this elevation are considered to have hyperhomocysteinemia. And in fact, there's an ICD-10 code that for this specifically. And as I said, it usually doesn't, you're usually not using it to talk about an inherited metabolic disorder. Okay, let's talk about homocysteine levels. Homocysteine and total homocysteine are amino acids, all right? Normal free homocysteine should be about 0. Total homocysteine is less than 11 to 15 micromoles per liter. And that's the typical normal range. Now, everybody with an inherited homocystinuria, whether it's from cystine beta-synthase deficiency, whether it's from cobalamin C, cobalamin D, whether it's from methylene tetrahydrofolate reductase, have total homocysteine levels without therapies greater than 15 micromolar per liter. Many times without therapy, these numbers can be hundreds, not tens. With therapy, the goal is we get them down lower, preferably less than 100 or lower than that. So some reasons to have elevated homocysteine levels. Just what are some of the reasons? Well, I've hinted at some of them. So the inherited metabolic disorders, and that's why we're here, right? We're going to talk about the inborn errors of metabolism. But remember, there's other reasons to have elevations in homocysteine. There's folate deficiency, which means low folate levels. It's really hard to have folate deficiency, but it's possible. In the United States, many of our grains are supplemented with folate, so we see a lot less of it than we did previously. There are places in the world like the Czech Republic where they don't supplement and they have a lot more folate deficiency. Vitamin B12 deficiency. This is a low vitamin B12 or cobalamin. This is not uncommon within the United States, and there's lots of reasons why you have low B12. Inflammation. So homocysteine is an acute phase reactant. And so if you have elevations in homocysteine and elevations in inflammatory markers, your homocysteine will go up. And this is the basis of some of the literature, if any of you guys have read some of the literature that talks about myocardial infarction and homocysteine. And the nitrous oxide, so laughing gas. Now, laughing gas makes everybody's homocysteine go elevated. If you've got an inherited metabolic disorder of homocystinuria, then laughing gas is kind of contraindicated. I'm going to complete the chat. All right, move it over here. Okay, homocysteine, homocysteine, and total homocysteine. This is terribly confusing, but homocysteine is the amino acid all by itself. Homocysteine, which is usually what's measured in your plasma amino acids, is a dimer. Protein-bound homocysteine is protein, and these yellow things are sulfur groups, and sulfur groups are sticky. Is protein-bound homocysteines. And total homocysteine in the blood is everything together. And that is typically what is measured and what the recommendation is. Now, some people will get homocysteine measured as part of their plasma amino acids. The challenge with this is not very stable, and so those numbers can go down with time. It is what the research studies all were based on 10 to 15 years ago, and it's notoriously hard to get a good accurate number. And this is actually a slide from Victor Korvich. For those of you who are familiar, he is out of the Czech Republic and has made a career of studying homocysteines. All right, this is kind of the grown slide for everybody that doesn't like biochemistry, but I think it's important to understand the family, okay? So we're gonna break this apart, but I'm gonna just talk about it quickly, but you'll see all of these parts speak again. So let's talk about pieces parts, okay? So we've got the things that are B12 responsive, so cobalamin G, cobalamin E. If your cobalamin C and cobalamin D doesn't work, this is the enzyme that has problems with methionine synthase. Then MTHFR is in this part of the pathway. So what does this part of the pathway? This is called the re-methylation pathway, and it takes tetrahydrofolate, makes it into 5,10-methyl tetrahydrofolate, makes it to 5-methyl tetrahydrofolate, and then helps convert homocysteine to methionine, okay? As I said, this is the re-methylation pathway. So when somebody says re-methylation, this is that part of the family, okay? Now, if you have a block here or a block here, your homocysteine goes up, right? So that's this part of the family. So let's talk about this circle here. This is methionine getting converted to homocysteine and then converted back to methionine. So why is this part of the pathway really important? Well, the re-methylation part of the pathway creates methyl groups, and that's what's bound to homocysteine to make methionine. But then methionine gets converted to homocysteine to be able to release those methyl groups. And what this does is it helps create adenomethionine, which will help give away methyl groups to lots of important things. It helps our DNA, it helps our protein function. All right. So if you have cystine beta-synthase or classical homocysteine, your difficulty is this part. You can't go homocysteine to cystithione to cystine. Okay, so you can see this is kind of the family picture with cobalamin C and D coming in, helping G and E out. Okay. So let's talk a little bit about biochemistry because I gave you that really hard picture. So there's a basic idea here. Usually every process in the body, two substrates, A plus B, becomes C. And if you think of every single step, and we can go back a slide here, every single one of these steps is A plus B becomes C, okay? If it works well, it's like a river that flows, right? No problems, there's no flooding, there's no damming. But if you have a biochemical disorder, A plus B can't be made into C. And what happens is you flood upstream of that dam, and you accumulate F and E and A. And that's what happens in all the homocysteines. The reason that you accumulate homocysteine is because there's a dam that doesn't allow homocysteine to get converted to whatever it needs to be converted, whether it's cystine beta-synthase or methionine. All right, we're going to talk a little bit about diseases at this point. So let's talk about cystine beta-synthase. Now, there's lots of things that get impacted with cystine beta-synthase, and we know that if we treat individuals early, we do not have all of these complications. So this is just like the textbook list. So CNS, if you don't treat it, you can get psychosis, there's mental health issues. If you don't treat it early, you have intellectual challenges, and you can develop movement disorders, which is one of those things people don't realize. The dislocated lenses, the fancy word for that is ectopic lentis. And then a lot of people have vision problems, so they have severe myopia. Skeleton, this is the description of excess height, long limbs. Over time, you develop osteoporosis and some bone deformities. And then the vascular system, which is the thing that most people think most about, is the thromboembolism. And we see venous more than arterial. So what's happening here? So as I said, this is our family picture, right? And I blocked out the stuff that we're not looking at. So this is like looking at half the family. All right. And so here, your block is down here, cystine beta-synthase. And homocysteine is not getting made into cystithione, right? And so cystithione and cystine become deficient. So this is like being downstream the dam, right? Above this, homocysteine accumulates. It starts to flood. Methionine accumulates. It starts to flood. Let's see. Yeah. So where can I treat it, right? Because if I'm losing this stuff and I'm accumulating here, what can I do about it, right? And so in this case, where does methionine come? Well, that comes from diet. That's why we restrict methionine in the diet. It's because methionine is going to get made into homocysteine. If I don't limit this, this is going to spin around in a circle over and over and over, and there's no way for me to get rid of the homocysteine. I can make homocysteine into methionine using basically the medication Betaine, which activates this particular enzyme. And there are research studies looking to see if we can make the enzyme work better or replace the enzyme altogether. So we could impact this, and that's like blowing holes in the dam and allowing the fluid flow. Okay. All right, so let's talk about re-methylation disorders. So the re-methylation disorders, as I said, are severe methylene tetrahydrofolate reductase deficiency, or MTHFR. And if you ask me why I say it over and over, it's because it keeps my letters in the right order. Cobalamin G and cobalamin E. Again, you're going to see strokes and you're going to see cerebral sinus thromboses. A lot of infants will present with the cerebral sinus thromboses. You can see intellectual disability, and you see a little more autistic features in this. Oops. Again, you see thromboembolism, and this is because the homocysteine is up. You can also see renal dysfunction during episodes, and there's a decrease in muscle strength. Now you'll notice this list is a little different, and if we go back to our little person here and see what the differences are, right? There's a few differences, but there's some very significant similarities. Now, this particular part of the chart is the re-methylation disorders, and so we've now kind of cut out part of the family, we've cut out the cystine beta-synthase part of the family, and we've got this particular part of the family. So now we have to address, how do I take care of this part of the family? So where can I treat this? All right, so I can convert the homocysteine to methionine. Recall, if this doesn't work and this doesn't work, it means I can't convert homocysteine to methionine, right? So typically my methionine is low and my homocysteine is high. And the only methionine I'm getting is in my diet. Okay, so I can convert homocysteine to methionine. This will help make this methionine more normal. And a lot of folks with MTHFR, cobalamin G and cobalamin E, methionine could be, before treatment, as low as 0. Now methionine is kind of important because remember, it's the donor over here for methylation. I could potentially add cobalamin, right? So hydroxycobalamin to make the methionine synthase work a little bit better, because cobalamin G and cobalamin E are part of that cobalamin process. I can add folinic acid or folic acid, depending on which abnormality I have, and that means I'm replacing the 3-methyl tetrahydrofolate. All right. In here, because the block is making methionine, I don't want to restrict methionine too much because I'll make the number lower, and methionine is essential for this part of the chart, for this part of the pathway. And I usually accumulate cystithione and cystine. So a lot of times we'll see an elevation in cystithione or cystithionine. So MTHFR, cobalamin G, and cobalamin E, this is based on the guidelines for treatment for the re-methylation disorders, which are published under Humler. So those guidelines say no treatment at all. Utilize that betaine to convert homocysteine to methionine. Now, this no diet part, a lot of clinical groups will actually use some level of protein restriction, so that you don't overwhelm it, because the problem is methionine gets converted to homocysteine. So if your methionines are relatively high, and you have to balance betaine, because betaine's making methionine, which is making homocysteine, plus or minus folinic acid or folate. There's actually not a lot of evidence that folinic acid or folate makes a difference in these disorders, but most people will add it, and plus or minus hydroxycobalamin. Now, hydroxycobalamin typically isn't necessarily going to help MTHFR, but it might help cobalamin G and E. Most people are really on it. All right, here is the cobalamin defects. Now, we might have an X or a J or an F. I know we have a bunch of folks with C and D, so the cobalamin defects. Now, I'm going to start out by saying there's 2 types of cobalamin C, and most people don't actually realize that. There's 2 types. There's an infantile form, and there's an adolescent adult form, okay? We'll talk a little bit, I'm focusing more on the infantile form because it is, to our knowledge, the more common form. But that may not actually be the case as individuals are picked up on newborn screening. So the infantile form, if you do not treat with hydroxycobalamin, will have intellectual disability and learning differences. And in fact, you may have brain differences. The infantile form develops retinopathies, And there's a discussion about whether higher doses of hydroxycobalamin will prevent those retinopathies and the macular disease. But that is in the process of being researched. Oops. Peripheral neuropathy is almost always seen in the adolescent adult form. In fact, it can be a presenting finding, such that individuals present with numbness and tingling in their feet. This actually can progress to paralysis. And there's an interesting young lady in Italy who is basically paralyzed from her cobalamin C, who presented with a progressive paralysis that eventually they identified as cobalamin C. And she's spoken in public, in fact, spoke at the International Family Conference 2 years ago, Danae? 2 years ago? Yeah. About kind of the challenges. The part that's challenging with this is that we usually find metabolic centers based out of pediatric hospitals, and there are certainly some adult metabolists, but there's a number of adult care centers that would not necessarily identify cobalamin C unless they were familiar with it. The other thing about cobalamin, the cobalamin disorders, you actually can have a congenital heart difference. You can be born with a heart difference, and most people don't realize that. Okay. So then we have what I'm going to call the combined disorders. And these are the cobalamin processings, which give us MMA and homocystinuria together. Now, clearly, cobalamin C is one of these disorders, and it's encoded by the gene MMA-CHC, which is how the name methylmalonic aciduria with homocystinuria comes to be. Cobalamin D1 is encoded by MMA-DHC. It is also called methylmalonic aciduria with homocystinuria. Cobalamin D2 actually is slightly farther down, and you only see homocystinuria with it. It is a much rarer form. It's encoded by the same thing as cobalamin D1, but the change is a little farther down in the gene, and only presents with homocystinuria. We have cobalamin X, which is an X-linked form, and it actually encodes a transcription factor which regulates the translation of cobalamin C. And so individuals with cobalamin X actually don't make cobalamin C and some of the other cobalamin processes. Cobalamin J, so we get cobalamin in our blood and we transport it into the lysosome, and then we transport it into the middle part of the cell called the cytosol, and then we do all of this processing of it, and then we stick it into the mitochondria. Okay, F and J process from the lysosome into the cytosol, and then there's also transcobalamin 2, which I don't know if we have anybody here, but they have difficulty transporting and importing cobalamin from the bloodstream, and they can have abnormalities in everything.
Dr. Chapman, we have a question here.
Yeah.
And so the question is this the same MMA that's in organic acidemia disorder?
It is, actually. So cobalamin C and D and F and J all are required to make the methylmalonyl-CoA mutase gene work. So in the organic acidemia, the problem is converting methylmalonyl-CoA to succinyl-CoA. And the thing that does that conversion is a gene called MUT, or MMUT, and that's methylmalonyl-CoA mutase. It requires processing with cobalamin A and cobalamin B, and then C transfers the cobalamin unit into MUT for MUT to work. So that's why The elevation from MMA, or the elevation of MMA, methylmalonic acid, comes from the block in the conversion from methylmalonyl CoA to succinyl CoA, because MUT doesn't have the cobalamin to work, and you accumulate or flood with methylmalonyl CoA, which is converted to MMA. And so that's part of the reason why cobalamin C and D1 are called the methylmalonic acidurias with homocystinuria, because they have elevations in MMA.
Thank you.
Did that make sense?
I haven't seen a question regarding it, but then they also said, are all of these autosomal recessive?
So almost everything is autosomal recessive except for cobalamin X, which is X-linked. So autosomal recessive is you have 2 copies of every gene, one from each parent, right? And to have almost all of these disorders except for cobalamin X, you have to lose the function of both copies, okay? And parents are typically carriers, so they have 1 functional copy and 1 non-functional copy. And to be affected, you have 2 non-functional carriers. So these are almost all recessive.
And then someone also just asked, I don't know if you can see these questions. There's a lot of questions popping in here.
Yeah.
What happens if the mutation in MMA DHC is the deletion of exon 2?
It depends on how big of the deletion is. So if you lose the entire function of the protein, you'll probably lose both parts. But if you're lucky enough that the exon allows the back end to work or the front end to work, then you would be able to have a partial. So it all comes down to what your protein looks like. All right, any more questions? We're going to talk a little bit about C and D1. And so this section is the section where MMA feeds in, because we need to make adenylyl cobalamin for methylmalonyl CoA mutase to work. And then the cobalamin processing goes on to do this homocysteine to methionine, and this is where methionine synthases. Usually C and D1 present with total homocysteine in an elevation in MMA. You might have a positive newborn screen with an elevation in C3, but you may not. And then I reviewed all of these things when I kind of gave you the overview. The infantile neonatal type has retinal changes and some intellectual challenges. You can have congenital heart differences and brain differences. Typically outside the neonatal period, we don't see decompensations. Before, in the neonatal period, you may see something that looks like methylmalonic aciduria with decompensation, significant acidosis, and hyperammonemia. All right, here is the management for C and D1. Prevent dehydration, reverse catabolism. And everybody's like, what's catabolism? So whenever we're sick or under stress, we start to break down our muscles. If we fast, we start to break down our muscles. Just breaking down our muscles is considered catabolism. And so most folks will treat catabolism using a dextrose-containing fluid with electrolytes, and they run it at 6 to 10 milligrams per kilo per minute glucose delivery, or 1.5 to 2 times maintenance. And then this is the guidelines that I mentioned before. So these are the guidelines for management and diagnosis for the cobalamin related re-methylation disorders, cobalamin C, D, E, F, G, J, and MTHFR. And then the vast majority of folks with C and D1 need hydroxycobalamin. There are some people who can receive hydroxycobalamin and normalize almost all of their biochemistry, and won't need any additional therapy. All right, chronic management for C and D1, because I thought there'd probably be a bunch of folks. It's hydroxycobalamin by shot whether you do this as sub-Q or IM, it depends on the clinic that you're in. The reason I don't have a dose here is because, as many of you know, getting higher doses can be challenging. And currently there's a study that's getting ready to start in Europe to look at high dose. And we've talked about starting a study here to look at high dose. Betaine, if your homocysteine is not under control with just your hydroxycobalamin. There's this thing called a folate sink that you basically lose, or you basically use a lot of folate if you have cobalamin C. It has to do with that re-methylation section. So a lot of people will need folate replacement. And then a normal diet is what the recommendations say. We almost always put people on a vegetarian diet, just not to prevent them getting too much protein at the same time. The goals of treatment is as low as you can go within reason, and most aim for less than 50 micromoles or better of total homocysteine. MMA, or the methylmalonic acid, almost always gets better with hydroxycobalamin. So there's not a lot of recommendations of where to put the plasma MMA levels, in part because understanding the significance of plasma MMA still is not well understood. Okay, cobalamin X. Do we have anybody with cobalamin X, or do you want me to skip it?
If you could still explain it, that would be helpful just for those who may be watching afterwards.
Yeah, so cobalamin X is actually the only X-linked disorder we're going to talk about here. And X-linked, so girls typically have two X's, boys have an X and a Y as their sex chromosomes. Girls get two X's, and then you randomly turn off one of your two X's. And then boys just get the one X. So cobalamin X is often seen predominantly in boys, although you can, in theory, have girls impacted. What it is this transcription factor. In fact, this transcription factor doesn't just control a lot of the cobalamin process. And what a transcription factor is, really, is it says, please make this protein that I tell you to make. All right? And so HCFC1 is a transcription factor that says, please make cobalamin C. In the absence of that transcription factor, it won't make the protein that makes up the cobalamin C. And so you get things that look very much like cobalamin C, and you get some other things because it's a global transcription factor, which means it turns on a lot of genes to be made. Oftentimes individuals will have severe disease. They have severe neurologic symptoms, seizures, intellectual challenges. As I said, the reason that it originally was described as cobalamin X is because it regulates the protein production for cobalamin C. And clearly, if you don't turn it on, you don't make protein. So it appears to be early and a severe form of cobalamin C at presentation. And you treat it like you have cobalamin C. There's not a lot of evidence this is going to make a difference because you may not make the protein at all. Whereas individuals with mutations in MMA-CHC probably make a little bit of the protein. Most of the time, it's not entirely eliminated. All right, let's talk a little bit about differences. Move this out. All right, so we're going to talk about CBS, the re-methylations, and then cobalamins, and cobalamins as in C, D, J, I, H, G, X. All right, so the first thing that I think people really notice is the difference in diet. So in CBS deficiency, or classical homocystinuria, you're in a low methylation diet, a methionine diet. And I'm hoping that you recognize when we did the pictures why this is the case. It's because there's no place for the homocysteine and methionine to go. The only way to get into the process is from your diet. The only way to limit methionine, homocysteine is through limiting methionine. In the re-methylation disorders and the cobalamins, you're really talking about a methionine a low methionine process. And so the only place you're going to get your methionine is from your diet. And so that's the reason why there isn't a restriction of methionine in the diet. Everybody uses betaine. The trade name is cystidine. Pyridoxine. So pyridoxine is B6, and I know we have at least one person with B6 responsive homocystinuria. CBS, if you're responsive, you get it. If you're not responsive, you don't get it. And we typically don't add it to re-methylation disorders and cobalamines. We may add it if we think that someone's going to be deficient, but typically we don't have to add it. Folinic acid and folic acid. And CBS deficiency, we're going to do it if they're deficient or if we're concerned about a deficiency. So we know that betaine doesn't work if you're folate or B12 deficient, especially if you have CBS deficiency. So a lot of people will get folate replacement with CBS because we want to make sure you're not deficient. The re-methylation disorders usually get folinic acid, and the cobalamines may or may not. There's not a lot of evidence one way or the other in terms of whether it's benefit. We can talk about the folate sink, and so a lot of times we will place someone on folate because we just don't want you deficient. All right, hydroxycobalamine. In CBS deficiency, only if you're deficient in B12. Some people will be on oral hydroxycobalamine or oral B12 to prevent deficiency given the restriction in the diet. In the re-methylation disorders, many people are on some hydroxycobalamine. On the cobalamine, C, D, etc. Or in some clinics, they have you do it sub-Q daily. Most people think sub-Q hurts less than IM. Most clinics give it as IM. As I said, the dosing is a bit variable. It has a little bit to do with the availability that you can get, and there's a number of studies that are getting ready to launch in the next year to look at the infantile form of cobalamine C to see whether or not higher doses make a difference. All right, at this point, I want to ask if anyone has any questions. I talked a really long time because I know that could be clear as mud. Danae has all of the slides, and I know that you can also see this again if you have any questions.
I'm going to see if I can unmute the lines here. I haven't done this before, so let me see if there's a mass way to, you know what, it will not let me just unmute everyone at once. So if you have a question, you can submit it through the Q&A portion or the chat.
I see the, okay.
So
So
a couple that popped up here.
For CBS, what are the about supplementation of the downstream cystine deficiencies? You're asking for whether you can substitute cystine and sulfates. There's not a lot of evidence, and there's not very many studies looking at cystine supplementation, and so it's very difficult to tell you on an evidence-based method whether or not that would be helpful. The few papers that are out there were relatively equivocal, but the one that was done the best, again, was relatively equivocal. So it's kind of hard to answer that question. I know that that's not very comforting. A lot of folks will get additional cystine. It tastes awful. It's got a free sulfur group. It's very hard to tolerate. So are there any HCU patients in Prague? You bet there's some HCU patients in Prague. Prague actually has one of the biggest groups of B6 responders with classical CBS deficiency in the world. And it's the Czech Republic certainly does. As for the other disorders, you see them some, but not as much. If you're going to talk about where places are more common, so it's interesting in the Mediterranean basin, and then in Brazil, you see a lot of cobalamin C. So when we ever have an international meeting in those locations, we see predominantly cobalamin C. Prague, we saw a lot of CBS, folks that had CBS deficiency. And as I said, there's this B6 fully responsive form that comes out of Prague. It's interesting because Harvey Mudd, many years ago, wrote the original natural history study that published in '86, I think. And Victor Korvich was actually his postdoc at the time, here in the States at NIH. And so he saw his first cobalamin C here. But there is certainly CBS in the Czech Republic.
In the chat sections, a parent is asking any tips on taking cystine and addressing the side effects, mainly stinky diapers.
Yeah, you smell like fish, right? So we've tried a few tricks with that. The cystine is, my patients describe it to me as being slightly slimy and having a taste. As we all know, the reps say that it doesn't. A lot of people mix it with pudding, or some people mix it with milk. Some people just break down and squirt it in all together as fast as they possibly can. So depending on your child will depend on the easiest way you will get it into them. But you can mix the powder in with other things. The stinky diapers. So one of the problems is betaine gets converted to this really awful smelling compound that smells like fish. And so I've tried riboflavin in some of my patients to try to make the fish smell go away. But oftentimes it's a dose dependent process. So ultimately, the only way to make it go away is to decrease the dose, which clearly adds risk.
Mm-hmm. One other tip I've heard from quite a few patients is Sunny D. Not the most healthy form of any juice, but Sunny D seems to be this magical elixir that works for many patients, and I think a lot of it has to do with the acid content. My dietitian always said, the more acidic something is, the more likely it is to mask the flavor. So
Yeah.
Lemonade, orange juice, Sunny D. As
I see somebody that puts soda, which is pretty acidotic.
Yeah.
Smoothies, yeah, yogurt. Any other burning questions? I'm hoping that was not as clear as mud. I think the thing that binds the entire family together is homocysteine, though, is how do you control homocysteine?
Oh, here we go. There's one more question. I'll read it so that way everyone can hear the question. 15-year-old boy with cobalamin A, MMA. Homocysteine levels have been elevated lately and folate is low. He also has celiac disease, so his diet is low protein and no gluten. He takes high dose of B12 IM. Some talk about genetic testing for MTHFR. Trying time take daily vitamins, Centrum Adult. Any thoughts?
So if you're folate deficient, that is not going to help your homocysteine. You could certainly be a carrier of the common polymorphism, of which 30 to 60% of the population is, and in folate deficiency, you see total homocysteines go up. The trick is to get the folate in. Has anyone tried just straight up folate as opposed to a multivitamin? You might even be, and if they have cobalamin A, then if you have G tube and they don't drink it, you can actually grind the folate up and put it into the feeds. If they eat it or drink it, then you can still crush the folate.
All right. Do you see bicuspid aortic valve disorders in CBS often?
No, but bicuspid aortic valve, let me try this again. So usually in CBS, you're going to see a vascular problem, often related to clots, venous more than arterial. Bicuspid aortic valve abnormalities are actually fairly common within the population. And so it is not a reported complication as common in CBS deficiency, but it's common enough in the population that there's no reason why you can't get two things.
Scrolling through the questions here in the chat. If the child is developmentally delayed, has there been improvements with treatment?
So it's this is a hard question for me to answer without a diagnosis. So CBS deficiency, with therapy, individuals seem to think better and have more emotional stability. With cobalamin C, people don't lose skills as much, but if they've lost something, especially if it's secondary to a stroke, it's more difficult. MTHFR, I think there is some evidence that early Betaine therapy makes things better, and that converts the homocysteine to methionine, so you're not methionine deficient. But there's not a lot of good studies about individuals started a little bit later in terms of intellectual outcome. It is one of the major deficits in any metabolic disorder is we've done a really horrible job of following neuropsych testing and intellectual abilities, and mostly because our measures aren't very good for individuals who may or may not have physical challenges.
It was a cobalamin D.
It's a D.
Yes.
Yeah, so usually the cobalamin can help a little bit, but it's a small population, so there's not a lot of great data. If Karen, you're the cobalamin A family, I'd give him more folic acid. You can give up to 5 milligrams. The worst that happens is they pee it out and they have brilliantly yellow urine.
We have time for a couple more questions if anyone has, more questions. Oh, here we go. Has anyone done a real study on health issues related to heterozygous partial CBS deficiency?
I know who this is coming from. The answer is no. What they've done is looked at heterozygotes with CBS and whether they're at increased risk for stroke. And the answer to that is it does not appear to come out when you're looking at a stroke population. But they have not looked for the stuff that you sent us with the
Glutathione.
Yeah, the glutathione. And so it's a really interesting thought because, and I still haven't cornered my boss who is a glutathione expert to see whether or not that would be it. Especially if you think about, so the question is a partial heterozygote, so a carrier. We don't think of them having full disease. So we don't think about a carrier for CBS deficiency having homocystinuria because that doesn't belong in the definition we all learned in the textbook. In general, we don't think of carriers having biochemical phenotypes. There are exceptions to this. Where this question comes from is cystine, which is what's not getting made when you dam up at cystine beta-synthase is required for this antioxidant called glutathione. And if you are just a little deficient in cystine, does this limit the amount of glutathione that you can make? No one's ever actually looked at that. So it would be interesting to see. It would also be really hard to do. But at some point we can talk offline what some of the options are.
And then going back to our cobalamin A, can you repeat dose of folate? Can you repeat the dose of folate you recommended? Sorry.
5 milligrams. Just go up. And if you have trouble with that, you can try methylfolate, which you can find from any online thing.
Thankfully, the internet's made things so much more accessible in some aspects.
You can order them, yes.
Yeah. Hold on, I'm going to click answer live. With high levels of methionine, what are the side effects of high methionine for the classical homocystinuria cystathionine beta-synthase patient population?
So really high levels, greater than 1,000, can lead to brain edema. And so that's the biggest risk. The other challenge is if your methionine levels are really, really high and you're in this loop, the circle loop, you run into the problem that it can, in theory, drive up your homocysteine levels. There are some people, I didn't talk about MAT13, that is the thing that converts methionine to homocysteine. So MAT13 is a common, I take care of rare, so common problem. So you could have CBS and MAT13 and you wouldn't do that conversion quite as well. But if you're converting methionine to homocysteine well and then homocysteine up to methionine, high levels can actually drive your homocysteine levels up. If you have MAT13 and CBS deficiency, you probably don't do that conversion quite as effectively, and so that homocysteine may not be elevated. As I said, methionine levels greater than 1,000 have certainly been described as causing brain edema all by themselves, and led to a handful of individuals having significant problems. And there's a few reported cases of methionines in the 800 range having that, but there were other things going on in that case.
And I just wanted to also add, if your methionine level is, that borderline 1,000, it may be good to look at your dose of betaine, because betaine cystine can, because it's converting the homocysteine back into methionine, it can be elevating your methionine levels. And there was a paper published within the past year or two about this specific thing. So really, it's important to be monitoring not just your homocysteine levels, but your methionine levels, and making sure they're not reaching that dangerous point. And then if they are, then kind of see if you can scale back on betaine.
And that's really where we see it. We see it in folks that are taking betaine. We seldom see numbers like that in individuals who are not taking betaine. Those are numbers almost always that are on a medication.
I want to make sure we get Kelly's question answered here. We'll take Kelly's, and then we have a question from Brian, and then we're going to stop questions because it's 8 o'clock. Kelly asked, she struggles with ligament pain due to lax ligaments. Is this common with HCU patients?
So one of the important things for so hypermobility is common in general in the population, but in individuals who have homocystinurias, especially CBS deficiency, but some of the others, is one of the important things that does the cross-linking in ligaments is cystine. And so if you're cystine deficient, you may not have that same cross-linking. But this is something that we hear a lot in terms of complaints, just like muscle complaints, joint complaints, and it's probably related to the cystine and sulfate issues.
Okay, and then the last question regarding glutathione says, we've reviewed the literature in CBS patients. Glutathione is normal, but metabolites are normal. We also see that in our patients.
Yeah,
So I think they're just adding.
Yeah, they're just adding. And I'll make a comment about that. It's really hard to move glutathione numbers in general. It is. The regulation is actually a step before you make glutathione. It's an earlier step.
Thank you, Brian. I will be linking you to Dr. Chapman afterwards. Last question here, and then I'm cutting them off, sorry. When taking betaine, are there any indicators that that it's converting methionine back to homocysteine, like high saccharin? Yes,
yeah.
Or other high amino acids.
So I always think of saccharin as being a marker that somebody's in fact taking their betaine, as is glutamine. So I know that they're taking it. So I actually think of it as going from homocysteine to methionine when I see those things, as opposed to methionine to homocysteine. I'll tell you that the way that I tell that if we're coming back to homocysteine is I look at those methionine numbers and try to figure out whether or not I'm seeing the methionine levels out of proportion of where I would like them to be. And if they start getting really, really high, that's usually a marker that we're having trouble with the homocysteine, total homocysteine numbers. That's usually the measure, that's usually the ratio that I'm looking at. And you see saccharin and glutamine elevated in individuals with CBS deficiency on betaine. You seldom see them in you seldom see it in individuals with MTHFR, cobalamin G, and cobalamin E.
All right. Well, that concludes tonight's webinar. If you do have more questions, Dr. Chapman has included her contact information here for you on this last slide. Please give her time, though, if you do email her, to respond to your questions, and she'd be happy to get back to you.
I do eventually get back to everybody.
Yes, she does.
Sometimes Danae needs to say, you haven't finished answering this question. Oh yeah, oops.
You can always feel free to CC me if, and a lot of the times I will be able to answer your questions, unless if it's regarding glutathione, then it's out of my ballpark. The downstream things just aren't in my field. But I thank everyone for attending tonight. We will have this webinar, it is being recorded, and we should have it available by the end of the weekend. So if you have any questions about what's being recorded, please feel free and email me. Otherwise, I will be emailing the presentation along with link to the guidelines for diagnosis and management for both classical homocystinuria and the re-methylation disorders out by end of weekend. Thank you, everyone, for attending.
Thank you, guys. Thank you for being so patient.
All right. Have a good night.